The third common belief people have is that I can't afford to wait. I've got to have an immediate ACL reconstruction because I need to get back to my sport. I've got a season to finish, or I've got one last season left in my career and then I'm going to call it quits. What I would really encourage you to do is to look at the best quality rehabilitation programs, and here's an example of one. And what they share in common is this prehabilitation phase. So this early rehabilitation before making a decision about surgery. And it seems the data are relatively sparse. We don't have a lot of studies studying the effects of prehabilitation program. But what we can say is the studies that have looked specifically at the effects of a prehabilitation program, the results at 2 years later, results for self-reported knee function, are superior to athletes and patients who have an early ACL reconstruction without doing prehabilitation. So my suspicion is that prehabilitation gives the athlete a bit of a chance to experience what rehabilitation is like. And I think biologically there's a plausible rationale to say that if you do a really good rehab program before you make a decision, then starting off, whether your decision is to continue with rehabilitation or whether your decision is to have a reconstruction, that getting that knee into as good function as it possibly can be before you then jump into surgery is only going to be helpful, not harmful. So you see here, this is an example of what we now consider as the gold standard ACL rehabilitation program, with a prehabilitation period of ideally 3 months, minimum 3 months, heavy strength training, lots of really high level function training. Then we might choose to have ACL reconstruction, which is followed by our typical acute phase addressing impairments, focused rehabilitation, moving to more strength focus, and then finally focusing more on the sport-specific demands. And you see some of the key metrics or the key goals of each phase there. The other thing that prehabilitation allows you to do is to build up that trust and rapport relationship with athletes, that we know some of these intangible kinds of things also play a role in a rehabilitation program. So building the trust relationship will help you with your shared decision making. You'll hear a lot more about shared decision making in part 2 of this series. We're going to touch on it a little bit today. We're going to touch on this idea of building confidence. You'll hear a lot more again about that in lecture 2. All of these sort of intangible things that we do without necessarily thinking specifically about what we're doing in rehabilitation, these are all part of a really good quality rehabilitation program that's going to give your athletes the best chance of succeeding. So I would encourage you to have a look at some of the literature in this field. They all talk about things that you can do to support athletes to feel confident during their rehabilitation program. They encourage you to collaborate with your multidisciplinary team colleagues, certainly regularly measure and provide feedback, and think about the type of rehabilitation environment that you are building. The other thing to keep in mind here again is the self-reported knee function outcomes. So here what you see are the KOOS. We talked about the KOOS a few slides ago. Self-reported knee function in pain, symptoms, activities of daily living, sports participation, and quality of life domains. They're the 5 domains that make up the KOOS. What I've illustrated here on this graph are the average self-reported knee function results for each of those domains of the KOOS, comparing patients who have had high quality rehabilitation program that you just saw on the last 2 slides to athletes or patients who have entered their data into the ACL registry and they haven't attended a high quality specialist rehabilitation program. And you see marked there in symptoms, in sport, And in quality of life, there is a clinically meaningful difference in self-reported knee function when we compare athletes who've received high quality rehabilitation to athletes who have received standard care. So it does make a difference at 2 years to how athletes perceive their knee function. It makes a difference what kind of treatment or what kind of rehabilitation they've received. And again, to remind you, if we're thinking about the belief that athletes have that I've got to rush and have surgery right away, prehabilitation, this period of intense rehabilitation before making a decision about surgery, that is part of a high quality rehabilitation program.